Welcome to our second series of webinars on the Canadian Adult Obesity Clinical Practice Guidelines, hosted by the Office of Lifelong Learning and Obesity Canada. My name is Denise Campbell-Scherer, and I'm the Associate Dean for the Office of Lifelong Learning, as well as a Professor of Family Medicine here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new clinical practice guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work. Just before we begin, I'd like to go over some items. We acknowledge that we are on traditional territories in Alberta of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. If you have any questions pertaining to technical difficulties or L3 programs and services, please use the chat feature of the webinar located in the middle bar of the bottom of your screen. If you have a question for our panelists, please use the Q&A feature of the webinar. Our panelists will answer several questions following the oral presentation. Some questions will be responded to through text in the Q&A window. You can at any point use the Q&A button at the bottom of your screen to submit questions. We anticipate many questions. Please review what has already been asked and upvote those questions you would like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be available next week. It will be sent via email to all those that registered. This link is for your personal use and is not to be forwarded or shared. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. We are very pleased today to welcome Dr. David Lau to present on the Science of Obesity webinar. Dr. Lau is a professor of medicine, biochemistry, and molecular biology at the University of Calgary Cummings School of Medicine. He is editor-in-chief emeritus of the Canadian Journal of Diabetes and past president of the Canadian Association of Bariatric Physicians and Surgeons. Dr. Lau was co-chair of the evidence-based 2020 update of the clinical practice guidelines on the management of obesity, led by Obesity Canada and CAPS. He also served as an expert panel member of the 2018 evidence-based Diabetes Canada CPGs. He has a long experience serving as an expert member for the 1998, 2003, 2008, and 2013 updates of those CPGs. He was also a primary panel expert committee member of the 2012, 2016, and 2020 update of the Canadian Cardiovascular Society guidelines for the diagnosis and treatment of dyslipidemia and prevention of cardiovascular disease in adults. Dr. Lau is involved in population health and clinical research programs in diabetes, obesity, and lipid disorders. David was honored as one of the top 20 notable Calgarians and top 50 Albertans in 2004 for his exemplary contributions to improve the health of Albertans. Once again, please join me in welcoming Dr. David Lau. I'll turn over to you now, David.
Thank you very much, Denise, for the kind introduction. It is indeed my pleasure and honor to participate in this obesity webinar series, and my presentation is entitled The Science of Obesity. What I'd like to cover over the next 30 minutes or so is the context and objectives of this particular topic, the science of obesity. And within this context, I would like to cover the following topics. First, to talk about the pathogenesis of obesity, and then to focus on how the brain is the central regulator of appetite and, importantly, energy homeostasis and obesity. Then I'll focus on adipose tissue-derived, gut-derived signals and how that connects to the brain to regulate eating behaviors. And then I'll spend a few more minutes on adipose tissue itself and how dysfunction of adipose tissue can lead to a large number of adiposity or obesity-related complications. So having a better understanding of the science of obesity will clearly have implications and inform us of better management of people living with overweight and obesity. And I'll sum up my presentation in the final slide with the key messages. In terms of context, having a better or comprehensive understanding of the pathogenesis of obesity will inform a rational approach to obesity prevention and management. There have been major advances in the science of obesity since the publication of the world's first evidence-based clinical practice guidelines on the management and prevention of obesity in adults and children back in 2007 that I led and chaired the guidelines. So it's been quite a few years, and we now have a lot more understanding. So it's very timely to update the 2020 guidelines. And I'm very honored to be a co-chair of this guidelines that are led by Obesity Canada and the Canadian Association of Bariatric Physicians and Surgeons, of which I was a past president. In terms of the objectives of this presentation, I'd like to provide you with an overview of the molecular, genetic, developmental, behavioral, and environmental factors contributing to the pathogenesis of obesities so that we can inform a much more rational approach to obesity management. The 2020 guidelines focus on redefining obesity as a prevalent, complex, progressive, and relapsing chronic disease characterized by abnormal or excessive body fat or adiposity to the extent that it impairs health. It is important to bear in mind that the recommendations and key messages in the guidelines are specific for people living with obesity and may not be applicable or appropriate for people with larger bodies that do not have health impacts from their weights. This slide illustrates that obesity is caused by a complex interplay of biological, psychological, and environmental factors, and it is influenced by the social and physical environment in which we live. But importantly, body weight is meticulously regulated by the brain, as illustrated on this cartoon here. Energy surfeit is converted into fat and stored in adipose tissue. Even small surplus of calorie intake, less than 1% over energy expenditure, can accumulate over years to lead to weight gain. And small cumulative imbalances of energy intake and expenditure can lead to weight gain and obesity. Suffice it to say that we all have inherent or innate biological defense of elevated body weight in individuals with obesity. Now, the next several slides focuses on the brain and how important the brain is in terms of its role in energy homeostasis and the development of obesity. Suffice it to say that the biological control of appetite is complex. A simple approach to understanding the neurobiology of obesity may be to divide the brain into three main areas that control eating behaviors: the hypothalamus, the mesolimbic area, and the prefrontal cortex. These neural networks have also been shown to be altered in obesity. Now, this is a busy slide, but what I'd like to highlight for you is let's focus temporarily on the nucleus, on the arcuate nucleus of the hypothalamus, as illustrated on this cartoon. The arcuate nucleus is often termed the hunger center, which controls the feeding behaviors. In the arcuate nucleus, neurons co-expressing neuropeptide Y, or NPY, and agouti-related protein, AGRP, when activated by hormonal and neural signals from the gut, adipose tissue, and the peripheral organs, they stimulate hunger sensation and trigger the food eating behaviors. The NPY-AGRP neurons project directly into the second set of neurons co-expressing pro-opioid melanocortin, or POMC, and cocaine and amphetamine regulated transcript of CART, which in turn suppress food intake. The homeostatic control of appetite in the arcuate nucleus is influenced by a number of factors: nutritional status, the nutrient sensing availability, taste and smell, as well as the food preferences. Upon eating, the sensory information on the volume and composition of the meals, and notably satiation, is relayed to the nucleus tractus solitarius, or NTS, in the brainstem by the vagoafferent fibers. The NTS in turn integrates and transmits the signal to the homeostatic control pathways in the hypothalamus. Now let's focus a little bit more on the hedonic eating component. Hedonic eating is based on the feelings of reward and pleasure that are associated with seeing, smelling, or eating food. This pathway means that the brain can crave food or enjoy food even when the person is completely satiated. The signals are transmitted by the dopaminergic, opioid, and endocannabinoid pathways via the respective receptors in the downstream targets. Dopamine is released in the brain, signaling a desire to eat in response to emotional triggers such as sadness, or environmental triggers such as the smell or the sight of delicious food. Hormones such as leptin, insulin, ghrelin, and glucagon-like peptide 1 or GLP-1 act on the dopaminergic pathway in the midbrain to modulate food reward and hedonic eating. The third component is the executive or cognitive lobe, and executive function in the prefrontal cortex is responsible for the executive function and overriding the primal behaviors driven by the mesolimbic system. Cognitive function works well under optimal conditions. In other words, if we have less stress, good support, well rested, and so on, that help to deal with adverse situations. We also know that people living with obesity may have a dysfunctional connection between the cognitive lobe and the rest of the brain, which can lead to the inability to control eating behaviors. There is significant crosstalk between homeostatic and hedonic eating, which in turn is mediated by the many endocrine and gut-derived signals. Leptin, insulin, ghrelin, and GLP-1 all act on the dopaminergic neurons in the midbrain to modulate food reward and hedonic eating. There's also another appetite suppressing network involving calcitonin gene-related peptide, or CGRP, neurons in the parabrachial nucleus that potently suppress eating when activated. But these neurons do not increase food intake when inhibited. The PBN CGRP neurons are activated by signals associated with food intake, and they provide a signal of satiety that has negative valence when strongly activated. So to summarize, the biological control of appetite is exceedingly complex and involves the integration of the central neural circuits with signals from the gut, adipose tissue, and other organs to influence homeostatic and hedonic eating. Executive control by higher brain centers on the decision of when and what to eat, and these neural networks have been shown to be altered in obesity. Now I'm going to turn your attention to adipose tissue derived and gut derived signals and how that connects to the brain to regulate eating behaviors. When it comes to adipose tissue and food intake, it's important to understand that leptin is a fat-derived hormone that is secreted by white adipose tissue in proportion to the body's fat mass. Leptin and insulin bind to the respective receptors in the arcuate nucleus to decrease food intake and increase energy expenditure. Decreased leptin levels would activate or inactivate the POMC and CART expressing neurons to promote feeding. Leptin also inhibits the AGRP NPY expressing neurons to increase appetite and decrease energy expenditure. So they act in a concerted manner between the hunger center and the satiety center, and all this is in part coordinated by leptin. It's also important to note that leptin resistance can also occur in some people who have excessive adiposity, which can perpetuate the vicious cycle of fat mass accretion. When it comes to gut-derived signals, GLP-1 and peptide YY or PYY are potent anorexigenic gut hormones secreted by the uh, L cells in the small bowel in response to food ingestion. GLP-1 and PYY promote satiation and satiety by activating the POMC-PYY neurons while reducing hunger via the AGRP and PY neurons. Cholecystokinin, which is another gut hormone, stimulates gallbladder contractility and pancreatic enzyme secretion, slows gastric emptying, can also have a negative effect on appetite. On the other hand, ghrelin is an orexigenic hormone produced in the gastric fundus, which stimulates or increases hunger and stimulates food intake. Now I'm going to turn your attention to the genetics of obesity. About 25 to 50% of the risk for obesity is heritable. So in other words, we really shouldn't blame people for overeating or not being physically active. A lot of it has to do with our genes. And indeed, over 140 genetic regions are known to influence obesity traits, be it eating behaviors, energy expenditure, and body fat distribution, and so on. The genetic risk of obesity interacts with the environmental influences in ways that favor positive energy balance and or result in a biological body weight defense. Geneticists have also started to uncover the genome of thinness to gain a better understanding why some people, despite very different eating and activity behaviors, continue to remain thin. Genetic as well as epigenetic variability among individuals explains why not all people exposed to the environmental factors that favor obesity would develop overweight and obesity. Let me emphasize that the genetic causes of obesity are very rare. And in many ways, they're summarized in this slide. Single gene mutations are known in a handful of conditions, such as mutation of the leptin gene, the pro-opiomelanocortin, and importantly, the melanocortin 4 receptor, or MCR4 or MC4R, which is by far the most common single gene mutations reported in about 2 to 5% of severe obesity in the pediatric population. Monogenic mutations, as I mentioned, are rare and only 11 forms reported. And there are syndromic obesity such as Prader-Willi syndrome, which is much more common than monogenic mutations. And of course, there are other causes of obesity due to endocrine dysfunction, such as Cushing's disease, hypothyroidism, and so on. And let me emphasize that hypothyroidism as a cause of obesity is exceedingly rare. And so in many ways, we do not recommend routine measurement of TSH as part of the investigation for endocrine causes of obesity. Now let's turn our attention to adipose tissue. Adipose tissue is a dynamic organ that can respond to alterations in energy stores through adipocyte hypertrophy and hyperplasia, or both. And adipose tissue can be as high as 50% of the total body composition, in other words, accounting for 50% of the person's body weight. Adipose tissue expansion is accomplished mainly by hypertrophy of the adipose cell, where the cell size can increase up to 7-fold. White adipose tissue is comprised mainly of large mature adipocytes, as shown on this cartoon, accounting for about half of all the cells within adipose tissue. The remaining cells are made up by preadipocytes. In other words, these are the precursor cells that can proliferate and differentiate to become the mature fat cells, as well as blood vessel lining cells, the endothelial cells, and macrophages and inflammatory cells also account for up to about 10% of adipose tissue. And in individuals with excess body fat, in particular, those individuals with more of the visceral fat, as estimated by increase in the waist circumference or the midsection, those individuals actually have more ugly fat cells, if you will, as I will describe in the next several slides. Subcutaneous fat accounts for about 85% of the total body fat, whereas the rest of the fat is what we often refer to as intra-abdominal or visceral fat. Visceral adipose tissue is often referred to as the ugly fat because of the association with decreased insulin sensitivity, increased lipolytic activity, lower angiogenic potential, and importantly, increased expression and secretion of pro-inflammatory adipokines or adipocytokines, referred commonly to as adipokines. And importantly, it also decreased the production of the good hormones. So clearly, individuals with more visceral fat are much more likely to develop all the associated adiposity related complications. It's important to understand that adipogenesis or fat formation involves the recruitment, proliferation, and differentiation of pre-adipocytes to acquire the phenotype of mature adipocytes. Adipogenesis is associated with the production of a large number of proteins that function as signaling molecules in glucose and lipid metabolism, as well as in energy homeostasis. Suffice it to say that regulation of adipogenesis is meticulously controlled at the transcriptional level within each adipose tissue depot. In addition to white adipose tissue, a small amount of brown adipose tissue also exists in adults and is involved in whole body energy homeostasis through non-shivering thermogenesis. And the reason why they appear brown is because of the abundance of mitochondria that helps to dissipate energy in the form of heat. What we also know now is the fact that there are what we call beige adipocytes that are thermogenic adipocytes that are present in white adipose tissue that can be induced by chronic exposure to cold temperatures and to some extent to exercise, through exercise. And they can now turn into the brown adipose cells, which help us to burn off the energy in the form of heat. So clearly, having a better understanding of the potential role of the brown and beige fat in the regulation of whole body energy metabolism, as well as glucose and lipid homeostasis, could potentially open new avenues for intervention and obesity management. As I mentioned, while the immature preadipose start to proliferate and differentiate to become mature adipocytes, a large number of proteins are produced, and many of these function as either hormones or cytokines. The two main ones that I like to discuss are leptin, which is truly a fat-derived hormone that binds to receptors in the hypothalamus to suppress appetite. In many ways, so it is the feedback hormone to link the brain with the peripheral organs, such as adipose tissue, the gut, the pancreas, and other organs, to overall control energy homeostasis. Leptin subserves a number of endocrine and metabolic influences, and importantly, it suppresses insulin secretion from the pancreatic beta cells and plays a role in insulin resistance. On the other hand, another hormone, adiponectin, is abundantly produced by adipocytes, and it exerts a number of what we refer to as pleiotropic effects, including influences on energy homeostasis, vascular function, systemic inflammation, and cell growth. Importantly, it is an insulin sensitizing agent or hormone which stimulates insulin secretion, and levels of adiponectin are often decreased in people with overweight or with visceral obesity and people with type 2 diabetes. Adipose tissue dysfunction may develop under conditions of continuous positive energy balance in people with an impaired expandability of the subcutaneous adipose tissue. So the inability to store excess calories in healthy subcutaneous fat depots can lead to increased visceral fat accretion as well as deposition of the fat in extra organ or in the ectopic organs such as liver or even the pancreas. In other words, outside of the adipose tissue. Adipose tissue expansion often leads to dysfunctional changes, which are characterized by inflammation and can lead to augmented production of fat-derived pro-inflammatory cytokines or adipokines. Importantly, at the cellular level, cellular hypoxia can be a driver for adipose tissue dysfunction. So overall, dysfunctional adipose tissue can lead to the development and progression of a number of adiposity or obesity-related complications, such as type 2 diabetes, hypertension, dyslipidemia, non-alcoholic fatty liver disease, cardiometabolic risk, and atherosclerotic cardiovascular disease. So now I'm going to turn your attention to the gut microbiome because we have learned a lot about how the gut microbiota can influence body weight and insulin resistance. The primary bacteria are firmicutes, which promote weight gain, whereas the Bacteroidetes are present more in lean individuals. In other words, they're associated with weight loss more than anything else. And we've heard a lot about probiotics and prebiotics. The prebiotics can alter the gut flora in favor of having more of the good bacteria that promote weight loss. On the other hand, bariatric surgery, or for that matter, even abdominal surgery and medications may have a huge impact on the microbiome in the gut, which can in turn affect body weight. So it is not at all surprising that after gallbladder surgery, some people may gain enormous amount of weight as a result of the surgery, but not so much of the surgical procedure itself, but because of the changes in the gut microbiome. So this is an emerging area of enormous interest and may have implications on obesity management. Now I'm going to turn your attention to adiposity or obesity-related medical complications. And as I mentioned earlier, adipose tissue dysfunction and excessive adiposity predispose to the development of many medical complications. And the common ones are insulin resistance and in susceptible individuals, type 2 diabetes. Visceral fat tissue is a more important source of excessive circulating adipose cytokines or adipokines, as well as inflammatory mediators than the subcutaneous fat tissue. Obesity is also linked to increased risk for 15 forms of cancer through the release of hormonal growth factors as well as inflammatory adipokines. Another concept that is emerging is the idea of obesity paradox. What this refers to is the fact that not all individuals who are living with overweight or obesity will develop complications such as type 2 diabetes or cardiovascular disease. The prevalence of metabolically healthy subjects who have obesity is estimated anywhere between 20 to 32% in the general population, depending on the data accumulated in different parts of the world and different countries and so on. Metabolically healthy phenotype not as significantly increased risk of all-cause mortality, but the clinical risk profiles were worse than those individuals who are metabolically healthy, lean individuals. Some people with excess weight might have a better prognosis with some chronic conditions or lower mortality than lean or normal weight unhealthy persons, thereby leading to this concept of obesity paradox. But in fact, one of the major contributors to the obesity paradox has more to do with the cardiorespiratory fitness. Now, I'm going to turn your attention to what happens if we trim off excess body fat, obesity management, And importantly, cardiorespiratory fitness are critically important in improving the overall cardiovascular health of people who have or who are living with overweight and obesity. Patients who are able to achieve a modest weight loss of 5 to 10% of their initial weight will experience dramatic improvement in terms of the cardiovascular disease risk factors, improvement in the lipid profiles, reductions in blood glucose and glycosylated hemoglobin, lowering of the blood pressure, importantly, decreased risk for developing type 2 diabetes and other obesity or adiposity related complications. It is also important to emphasize that while it is easy to help, relatively easy to help people to lose weight, but the majority of individuals experience the weight regain over time. And for many years, we blame our patients for either lack of willpower or the failure for not adhering to our recommendations, when in fact we now know that following weight loss, the body triggers a number of compensatory biological pathways in such a way that people who have lost weight will now start to experience increasing hunger, primarily because of a reduction of the satiety hormones such as GLP-1, cholecystokinin, and PYY, while at the same time, the hunger hormone ghrelin increases following weight loss. And in addition, following weight loss, the resting metabolic rate goes down by as much as 15 kilocalories per kilogram of weight loss. So all these changes in terms of metabolic and hormonal changes following weight loss are adaptive responses to tell the individuals to regain the weight. So this is a very important paradigm shift to inform us that we now have a better understanding why keeping the weight off is such a big challenge. We have a physiological explanation for the weight regain. Having gone through the science of obesity, what are some of the implications for obesity management? And specifically, what advice do we as healthcare professionals inform our patients living with overweight and obesity? Of course, medical nutrition therapy and regular physical activity are the cornerstone approach to improve health for most people living with overweight and obesity. In the 2020 guidelines, we avoided the term diet, but replace it with medical nutrition therapy because we really don't want to have patients focus on diets and so on, but rather we're looking at nutrition therapy to help individuals to lose weight. Adjunctive therapies such as psychological, behavioral support, as well as pharmacological and in selected individuals, bariatric surgical interventions may be necessary to meet the individual's health-related or weight-related outcomes. Treatment options for obesity need to focus on the health outcomes rather than on weight loss alone. And importantly, we need to individualize our recommendations to customize that to the individual in order to make sure that the individual can make reasonable, specific, and realistic and achievable goals to help them to achieve the weight loss as well as improvement in terms of their overall health. And when it comes to treatment options, having said that nutrition therapy and regular physical activity are the cornerstone management of weight, we also have to focus on psychological intervention or behavioral intervention, helping the individuals to manage the sleep, manage the stress, and if necessary, cognitive behavioral therapy can also help to accelerate and augment the improvement through health behavior intervention. On the other hand, because modest weight loss only brings about 3% body weight loss based on data from meta-analysis, So in many patients, this may not be an adequate weight loss to achieve the health goals or to improve the adiposity or obesity-related complications. And this is where pharmacological therapy is extremely helpful as adjunct to healthy behavior intervention to augment the benefits from the healthy behavior intervention, but also to sustain the weight loss and to prevent weight regain. We now have 3 different medications available for the long-term management of obesity as a chronic disease, namely liraglutide 3 milligrams, combination pill of naltrexone bupropion, as well as orlistat, which has been on the market in Canada for more than 20 years. The criteria for pharmacotherapy is individuals with an operational definition of obesity with a BMI of greater or equal to 30 kilogram per square meter, or individuals who have overweight but with one or more comorbidities or complication related to obesity, 27 kilogram per square meter or greater. On the far right panel, we're talking about bariatric surgery, and there are a number of different procedures available, and the specific procedure which is best suited for the individual should best be discussed with the experienced surgeon. And this could include sleeve gastrectomy or the gold standard Roux-en-Y gastric bypass, which is now performed mainly through laparoscopic procedure rather than an open approach. And the more challenging procedure, the biliopancreatic diversion with or without duodenal switch, is a better procedure for, if you will, the treatment of individuals with overweight or obesity who also have type 2 diabetes. The criteria for bariatric surgery really have not changed over the years, and that is individuals with a BMI greater than 40 kilogram per square meter, in other words, greater than class 3 obesity, or individuals with class 3 obesity with adiposity complications. And increasingly, in the guidelines, we now recommend individuals with an operational definition of obesity, which is a BMI greater than 30, but who have poorly controlled type 2 diabetes. And these are individuals who can benefit from bariatric surgery. Unfortunately, bariatric surgery is still not readily available, and the wait time can vary between 1 to several years, depends on the province that you live in, and so on. So I think it's important to understand that these specific interventions support the medical nutrition therapy as well as regular physical activity. So to sum up in my presentation, obesity or excess adiposity is the result of an imbalance between energy consumption and energy expenditure by an individual. The causes of obesity are complex and result from interactions among biological, behavioral, psychosocial, genetic, and environmental factors. A better understanding of the cellular and molecular pathways leading to the genesis of excess adiposity that impairs health will guide the practitioners to develop a more rational approach to the management of this exceedingly complex, chronic, and relapsing disease, which we often refer to as obesity. So thank you very much for your attention, and I'll be happy to answer any questions.
Thank you so much, Dave, for that fantastic talk. On the panel today, in addition to Dr. Lau and myself, we have Dr. Sean Wharton, who is the co-lead with Dr. Lau of the Executive Committee for the new Canadian Adult Clinical Practice Guidelines for Obesity. Dr. Wharton has his doctorate in pharmacy and medicine. He is the medical director of the Wharton Medical Clinic, a community-based internal medicine, weight management, and diabetes clinic in Toronto. He is an adjunct professor at McMaster University in Hamilton and York University in Toronto. And he also works as an internist at Women's College Hospital and the Hamilton Health Sciences. Dr. Wharton is a researcher and is qualified as a diplomat of the American Board of Obesity Management. So welcome, Sean. And I can see here that we already have a couple of questions to kick us off. So Holly has a question. She's wondering whether having the ascending and transverse colon affect hormones and microbiota with respect to weight. She knows she has a client who now has a B12 deficiency and is gaining weight. And she's wondering about nutrition, whether the nutrition therapy she has should change focus. So does anybody want to tackle Holly's question?
Denise,
Go ahead, David. Yeah, you can go ahead.
I think the whole question about the microbiome is really a very interesting and fascinating one, because we're just starting to understand how the microbiome can actually alter nutrient availability, as well as many other influences the biome has on the body. So with respect to the question in terms of surgery, or for that matter, after surgery, individuals may experience a tremendous weight gain, or in some situation, in rare situation, weight loss. And that has a lot to do with the changes in the microbiome. So in terms of the question, well, how best can we change the dial, if you will? One way to go about it is to consider probiotic therapy. Or prebiotics. It depends on the specific situation. But again, this is an area we're just starting to gain some understanding and knowledge on. So it's an open area, and I wish I could have more information to help. So maybe Sean can supplement the question with his answers.
Yeah, terrific answer, David. As well, I would, if you're concerned about the vitamin B12 deficiency that you're seeing your patient having after the surgery, then it's somewhat difficult to try to define exactly where you think it's coming from. Could it be the microbiota that has changed? Could it be the type of surgery that she had? We know that gastrin is produced in the stomach, and it helps with the absorption of different vitamin levels. And if the patient is not getting that as much as previous, then there may be a challenge. So what you need to do is just continue to monitor all of these vitamin levels, and then replace the vitamin levels that are challenging. So if it's iron is down, it's a vitamin B12 that is down, then the patient needs to actually get it. Now, will a dietary change, which is what you asked about, a medical nutrition therapy, bring back that microbiota? If that's what the causative factor is, we don't even know. Or will it make the vitamin B12 absorption better? Possibly. So working with a dietitian post-bariatric surgery will definitely be of benefit. But what we've really seen is just make sure you're giving them the supplemental components. If that's vitamin B12 injection, then they need to actually get that, and then work with dietary changes, see if the vitamin B12 comes back. But they need to get those supplementations, because there's so many changes post-bariatric surgery, and we don't understand them all yet. And we just need to monitor, or else we end up running into trouble.
Thanks, Sean. And just I would like to highlight that in the bariatric section of the guideline, the third chapter on the post-bariatric care has some really helpful information for attendees around what that monitoring would look like as well, just in case anyone wants to check that up. So Danielle is asking a question that since it's knowing that weight loss can cause detrimental effects on hormones related to appetite, as well as body expenditure, why is this still a recommendation, especially for patients with healthy adipose tissue? And that's just a great question, especially around the yo-yoing effects. David, did you want to comment on Daniela's question?
Yeah, absolutely. Well, thank you, Denise. And thank you, Daniela, for asking a very important question. I think in my intro, under the new definition of obesity, I also qualify my comments by stating very clearly that whatever recommendations and key messages in the obesity clinical practice guidelines, they're specifically intended for the people living with obesity, who are suffering from the health complications associated with obesity. And it may not be applicable or appropriate for people with larger bodies who do not have or experience the health impacts from the weights. So in other words, you're asking the question, if I'm healthy and having a bit of excess body fat, why would you recommend weight loss? I think that's an excellent question. We do know that the concept of the healthy metabolically healthy obese individuals, if you're looking at over the long term, they do develop adiposity-related complications. But what we don't know is the time duration. And a lot of it depends on a number of factors. So by and large, I think it's important to emphasize not everybody with excess body weight require intervention of any kind. Only if the person feels that the excess weight is causing health issues or psychological or behavioral issues, that I think we would recommend intervention in the form of medical nutrition therapy and regular physical activity and adjunctive therapy, including pharmacotherapy. But that's not for everyone. So your question is very well worded, and we really need to emphasize individualizing and customizing our recommendations for any form of intervention, be it non-pharmacological or otherwise.
Thank you so much. I want to just move on to the medication questions, just keeping an eye on time. So Bruce and Lisa have a couple of questions about medications. And Bruce is asking if we could detail a little bit the pros and cons of the pharmacologic agents recommended in the guidelines, Sean. And in follow-up to that, David, Lisa's asking about phentermine, and whether, which is also called Duramine, as to whether that's a reasonable medication to use and how it differs from naltrexone, bupropion. So, Sean, do you want to address Bruce's question?
Sure. So, Bruce, in addressing that, I think the big thing that we wanted to emphasize is that pharmacotherapy is one of the pillars. Pharmacotherapy is going to change. And so we have some things now and we'll have a lot more later. It just needed to be really clear to people, to everyone, that this is a disease state that can be treated with medication. Just like cancer is a disease that's treated with surgery and medication, and diabetes and heart disease, this is one too. Now, the ones that we have now, I'll quickly talk about, but the important thing is that there'll be more coming. So orlistat is the first one that we've had. It doesn't work all that well because it doesn't work in the brain. And David very clearly talked about the fact that most of the pathophysiology is within the brain. The genes that code for elevated weight are brain genes. Orlistat is not one of the better medications we see working when we're in the real world setting. The two other medications work within the brain neurochemistry, and they both work relatively well. They are still some of the newer ones that we have, and as I said, we'll get new ones that will bring us past the 10% weight loss, getting into the 15-20% weight loss, getting closer to our bariatric surgery levels. But even the ones that we have right now end up working in the brain, calming down the brain, making a patient more capable of doing the foundations. And the foundations that David spoke about were medical nutrition therapy, getting on a good dietary intervention, and then being able to maintain physical activity. So those two things are maintained much better when you have even these medical treatments, pharmacotherapies that we currently have. And the big deal with them is that they're relatively safer than things we've had in the past. So 20 years ago, the things that we had weren't safe. Now we're in a much better position. They work relatively well and they're relatively safe.
Thank you, Sean. So David, did you want to address Bruce and Lisa's questions as well around some of the other older agents?
Yeah, I think Sean mentioned that both liraglutide and combination naltrexone bupropion are good long-term therapy for chronic weight issues. So in terms of who might benefit from liraglutide better than, for instance, naltrexone bupropion combination, the obvious ones are those individuals who have prediabetes or who have diabetes, because the liraglutide also has a beneficial effect on glucose metabolism, so that because it stimulates endogenous insulin production as well as inhibiting postprandial glucagon release following meals. So in that situation, liraglutide would be a better agent. If you're worried about more in terms of food cravings, then Contrave or naltrexone bupropion combination pill might be a better option. But again, whatever we talk about, it's very important to focus on the long-term management, especially after they reach what they call, what we often refer to as a plateau. After they lost the weight, the weight curves tend to flatten out, and that's when they reach the steady state. And the common mistake that we often make is to stop the medication, when in fact, they will benefit to continue with the medication. So even though the weights don't go down much or stay the same, if the medication is stopped, the weight will start to go back up. So I think that's a very common misperception in terms of discontinuation of weight loss medications. Now, with respect to phentermine, it is available for short-term management in the States, whereas in Canada, it's really fairly restricted. In terms of its effectiveness, certainly for the short term, it can bring about 5 to 7% body weight loss. But again, you have to bear in mind that phentermine being an adrenergic agent, it has a number of side effects that sometimes would preclude the individuals from taking it over the long term. And we don't recommend long-term therapy because of the potential side effects.
Mm-hmm. Thank you, David. And just briefly, could you comment just on the use of the medications together with surgery, pre or post?
Oh, absolutely. Surgery is certainly helpful to help the individuals to achieve long-term and sustained weight loss. But we now also know that even with biliopancreatic diversion, individuals can still regain some of the weight for all the reasons that we talked about. And that's where pharmacotherapy becomes actually very helpful for those people who have regained weight following bariatric surgery. And importantly, a large number of centers are using combination meal replacement programs as well as pharmacotherapy to help individuals to lose some weight before bariatric surgery. And the rationale behind that is really to ensure that they do not have fatty liver disease. So that it makes it so much easier for the surgeons for the surgical procedures if they have a smaller liver and so on. So again, these are highly individualized, but increasingly many centers are considering not just meal replacement therapy before the operation, but also combination.
Thank you, David. So Daniela has a question. Just if we could go over which tests do you recommend to investigate endocrine dysfunction related to obesity? And I think there's a whole chapter on that, but I think David, perhaps you and Sean could comment on Danielle's question.
Yeah, and I'll let David specifically answer that. But just before that, I'm going to as well complement the answer that David gave about the use of medication post-bariatric surgery and around the timing. So we use the medication a lot of times before the surgery. It can get the weight down, put the person into a position where the surgery is less risky because their weight is lower, and that works well also with the meal replacement therapies. And post-surgery, we've seen that a number of people have a rise in their hormones, such as their GLP-1, their good hormones, and a decrease within their bad hormones. And then what we sometimes see at year 3 or 4, that rise in the GLP-1 starts to come back down. When it comes back down, the weight starts to go back up. So therefore, the use of a GLP-1 analog may be a positive aspect at that time. And we actually showed in a study, we've published this, where we had 117 patients who regained weight post-bariatric surgery. We put them on liraglutide, a GLP-1 analog, and their weight went back down. So so we have one of the largest case series showing that. So we do have now really good evidence that we should be using all of these pillars in a combination. So surgery and medication and psychological intervention, use them individually, or we can interchange them. And now I'll let David go on with answer to the endocrine question.
Okay.
Thank you, Sean.
Okay, first and foremost, endocrine causes of obesity are exceedingly rare. We're talking about less than 1% of patients living with obesity, more so with obesity than overweight. In terms of specific investigations, the one thing I would caution everyone on this webinar is not to order TSH, because hypothyroidism as a cause of obesity is exceedingly rare. No doubt that hypothyroidism can certainly add on or aggravate the weight gain, but as a cause of obesity is extremely unlikely. And because TSH test is expensive, even though it's easily ordered and patients don't have to pay, it racks up a lot of money over time, and it's totally unnecessary because as I say, really we strongly recommend that we don't do that. So other endocrine causes include Cushing's syndrome, which again is not a common problem, and especially when you're dealing with Cushing's disease. There are other syndromic obesity for which we really don't have a lot of specific tests for other than genetic testing. But the bottom line is, for those individuals, they typically manifest the trait of being compulsive overeaters. So those are the individuals we can readily identify as having, quote unquote, the hypothalamic cause of obesity. So going back to your question in terms of endocrine causes of obesity, they're extremely rare and uncommon. So there are situations such as leptin deficiency or leptin receptor deficiency, but these are rare as hen's teeth. And really, we're talking about a handful of cases in the world.
Wow. Okay. Thank you, David. So I'm just mindful this is such a rich discussion, and I know there's questions still in the chat box. I encourage everyone, we have the Obesity Canada Connect Pro, which is a really dynamic online community for additional questions and insights, and you can have the link there in your chat box. I think we probably have time just for one more, and oh gosh, we could probably talk for another half an hour about these, but Charlotte has a question just to follow on what we were speaking of before that we might be able to address quickly around how long you would keep people on medication even when their weight stabilizes. And do we have some long-term use, some studies with regards to the long-term use of those medications?
Well, I'll start. So liraglutide has a 3-year pre-specified study looking at weight loss as well as the delay of delay of onset of type 2 diabetes. So that's the longest trial reported for weight loss medication is 3 years. But again, what we want to emphasize in the guidelines is the fact that obesity is a chronic relapsing complex condition. So therefore, it requires a long-term solution. And the analogy is very simple. For people with diabetes who are not achieving glycemic control, we recommend healthy behavior intervention along with pharmacotherapy. Now, when the patients achieve the recommended A1C goals, we continue with pharmacotherapy. None of us would consider stopping the medication. We may reduce the number of medications, but I think stopping medications would not really be even considered. So I think we really need to engage the same paradigm and apply that to people living with overweight and obesity, bearing in mind that obesity is a chronic disease. Now, for regulatory requirements, the pharmaceutical companies only have to submit data on 1-year study. But that doesn't mean that we should stop after 1 year. And we have, and I'm sure Sean can tell you that we have patients who are on long-term therapy because if we stop the medication, people will regain the weight.
Wonderful. I just really appreciate all the richness of these answers. And all of the expertise on the panel today. And thank you so much for coming and supporting the webinars and the KT for these guidelines. There's lots of questions popping up in the chat, and I just really direct everyone to the OC Connect Pro as well. You'll also find lots of helpful information in the full chapters of the guidelines, which you can find in full text on the Obesity Canada webpage. And that might be also a really helpful source for people. So thank you ever so much, Sean and David.
Absolutely. Thank you.
Okay, and thanks also to all the colleagues at Obesity Canada and the Office of Lifelong Learning for all the logistics behind these sessions, and to all of you attendees for coming. As mentioned by Nicole in the chat box and on the screen, there's always really helpful to have feedback, really appreciate it. So please send us your comments and we'll try to incorporate those in our work. So thank you, everybody.